Thank you, Dr. Jihani, for the kind introduction. Thank you to the organizer and to Magdi Iacopo for the invitation. It is always a pleasure to be here. Let's switch perspectives for a minute. So we have just heard a brilliant talk about the genetic factors that may influence atrial fibrillation in a general population. So let's look at patients who actually have a specific genetic disease that affects the heart muscle in particular, and how does that translate into the risk of developing atrial fibrillation, and how does this in turn translate into management and outcome. So we don't have time to go into the whole spectrum of inherited cardiomyopathies. As you can see here, though, there are a number of conditions, including hypertrophic, dilated, non-compaction, and restrictive, that have huge areas of overlap because some of the genes involved are in the actual machinery of the heart. So sarcomere, Z-disc, structural genes of the heart. And it's not surprising that there is overlap both in genes, phenotypes, clinical manifestations. However, then there is then this desmosome disease, which is arrhythmogenic right ventricular cardiomyopathy, which seems to stand a little bit aside. Each of these genes can deeply influence the metabolism and the function of the sarcomere and the cardiomyocyte and the whole heart, and in turn will have some arrhythmogenic properties as well. Just for the sake of time and for my personal bias, I will concentrate on hypertrophic cardiomyopathy, which is one of the most pure paradigms of genetic heart disease. It is, as you know, usually transmitted in a autosomal dominant fashion in families, although penetrance is incomplete, and it is characterized by what's so-called unexplained. It's actually genetically driven hypertrophy of the left ventricle, as well as another host of different manifestations, which, for example, mitral abnormalities, which actually are primary components of the phenotype. And in fact, atrial remodeling and atrial dilatation are important features of atrial fibrillation, even in patients with otherwise mild phenotype. Why this is probably a number of hemodynamic factors, as well as probably the fact that there is a primary atrial myopathy in HCM. After all, the genes are the same, with few exceptions. For example, beta myosin is not as represented in the atria as in the ventricles, but otherwise the genes are pretty much the same in the atria and the ventricles. So any disease affecting the ventricles are very likely to affect the atria as well. And there are a number of indirect pieces of evidence that the atrium is in fact abnormal in hypertrophic cardiomyopathy. I will not go into this, just to tell you that we have some in vitro data from human cardiomyocytes taken at the time of surgery in our Professor Pugliesi's lab in Florence, who is a biophysicist involved in study of heart muscle and particularly cardiomyopathies. And you can see that some of the abnormalities that you find in HCM ventricles, such as increased calcium sensitivity and lower force generation, are the same you can find in the atria. Whatever the reason for left atrial dilatation, which is in fact common, this often comes with left atrial dysfunction as well, so that the left atrium in HCM in some stages of disease seems to be not contracting very well. And you know that when the ventricle responses to triggers with hypertrophy, the atrium cannot often, you don't see left atrial hypertrophy, you see fibrosis of the atria, much less easy to see hypertrophy. What it does, it becomes larger. And one of the reasons for this is that the afterload of the left atrium is actually the end diastolic pressure of the ventricle. So in fact, the left atrium becomes a very useful barometer for the clinicians. And this applies to no matter what condition you're looking at, whether it's hypertensive heart disease, general population, specific heart conditions, valvular heart disease, whatever. Left atrium is an index of how the overall system is keeping in balance. It is a very useful barometer. And when it dilates and it starts contracting poorly, just looking at fractional shortening of the left atrium, which is very easy to do, this is, first of all, an indicator of outcome, and secondly, it predicts development of atrial fibrillation. so much in HCM as in virtually any other condition. This is particularly important in HCM patients because the age at which atrial fibrillation develops is very early. So we've looked at all the data that Professor Bono and others have shown. You see that we're talking about the 65, 70, 80-year-olds. But here we are talking about 20, 30, 40-year-olds. And you can see this is a study I published several years ago. Remains probably, unfortunately, one of the few studies looking at this. We need more data, but you can see that how the age at onset of atrial fibrillation can be very, very early, and the average age of onset in this particular study was only 55 years average. And this is really a turning point for two reasons. First of all, because atrial fibrillation has an impact on outcome. And secondly, because these are patients who may have been very, very well until that time. Few symptoms, active lifestyle, few drugs, medications. The onset of atrial fibrillation really tilts the balance towards increased medicalization, heavy drugs, including anticoagulants and antiarrhythmics, procedures. So it really changes the quality of life dramatically, as well as risk. And you can see still from the same study, not surprisingly, that the risk of mortality, stroke, and functional deterioration in these patients increases very much. And it is interesting to note that the younger the age at onset of the arrhythmia, the worse the consequences. So younger patients developing AF will have more adverse consequences. Whether this is just an index of more aggressive disease, more aggressive HCM, or whether this is the consequence of AF itself, we don't know. It's probably a mix of the two. It's like a vicious circle. So the more severe the disease, the more likely you are to have AF, and then AF makes it even worse. And as Robert Bono showed us a couple of years ago, 1983, one of his many interests was HCM at the time at the NIH, and he showed us beautifully how much the HCM ventricle relies on the atrial kick for filling. If you lose this important component, and many young patients, as well as the older patients, have this kind of pattern. If you look at the mitral valve filling pattern, this is what you are losing if you go into atrial fibrillation. So as much as 50% of your filling. And so when we were talking about asymptomatic atrial fibrillation, this is usually not the case here, because these are stiff ventricles. Young patients have very, very fast conduction rates. They lose the atrial kick, and the consequences are the worst possible you can imagine. We have several cases in the literature in which induction of rapid AF degenerated, well, first of all provokes subendocardial ischemia, as you see here, degenerating into VF. And not surprisingly, in ICD carriers, pre-existing atrial fibrillation predicts shocks. So there is a link between atrial fibrillation and risk of sudden death, as well as heart failure in these patients. Now, it is important to remember that this is not a chronically progressive disease such as idiopathic dilated cardiomyopathy, for example. This is a disease that can be very stable over time, and it's sort of biphasic. There is an early stage in which the disease is hypercontractile. The LV is very, very potent and hypercontractile. You have obstruction caused by systolic anterior motion of the mitral valve. And here you tend to have atrial remodeling because of, I will show you, mitral regurgitation, functional mitral regurgitation. This is usually only the left atrium dilating, whereas later on in the disease, some patients, not all fortunately, just sort of 15 to 20% tend to progress, and only 5% will eventually go into the end stage, as you see here, which is mostly a restrictive stage with huge biatrial dilation. And these are the two contexts in which atrial fibrillation tends to occur more frequently. You see why obstructive patients develop atrial fibrillation. This is not surprising. It's not only the gradients, the increased afterload, it's the mitral regurgitation, which can be very severe and very dynamic. If you can see it mild at rest, but if you exercise the patient, the degree of mitral regurgitation will increase a lot. And so that the atrium is stretched, gets fibrosed, dilates, and eventually goes into atrial fibrillation. When a patient with obstruction goes into atrial fibrillation, this is not very good news. This is probably a time for surgery, or maybe we have missed the ideal timing for surgery. remember that if you operate on somebody doing a myectomy, relieving the gradient, we know that there is very good survival benefit. The symptoms are virtually cancelled after the operation. However, atrial fibrillation is the single complication post-surgery which will make life hard for your patient. In fact, if you have atrial fibrillation and obstruction as compared to atrial fibrillation in the absence of obstruction in HCM, the mix of the two seem to be particularly dangerous in these patients. And what is most interesting, and this has been shown by the Toronto group here, but the Cleveland group have recently published very similar data. If you look at the predictors of mortality following myectomy, so after successful surgery, you will see that history of pre-op atrial fibrillation and a left atrial dilation independently predict outcomes. So even if you have a successful myectomy operation, but you get there after AF has already occurred, your outcome will not be as good as in patients who get operations earlier with a smaller left atrium and without the arrhythmia. This has to be kept in mind because we probably need to change our mind and start operating earlier, provided we can do it safely, of course. If you're talking about atrial fibrillation in the context of disease progression and end-stage progression, it is important to remember that the earlier the onset of the arrhythmia, the most severe the symptoms caused by the arrhythmia. If the disease is really end stage, truly end stage, and with these atria, it's not surprisingly they do go into persistent and then permanent atrial fibrillation. Well, the later the arrhythmia is developed, the least the consequences, because the filling of the ventricle is restrictive. The atrial component of the filling is very, very small, and this is when patients can sometimes already be so symptomatic that AF will not make a difference. However, it makes a huge difference in terms of embolic risk. These are really very high risk patients for embolic complications. And it is obviously the most difficult to get them back into rhythm once they do go into AF. And talking about treatment, none of the speakers before have addressed treatment because this is going to be part of the second part of the of our conference here. However, I would like to just mention a couple of concepts here. There have been studies, huge studies in the community showing that there is little difference in outcome in terms of patients who are treated conservatively with rate control as compared to those who are treated aggressively trying to maintain rhythm control. And in fact, sometimes some studies show that if you aim for rate control, this makes patients sicker, you give them more toxic drugs, they are hospitalized more often as compared to those that are treated conservatively with rate control. And as far as you anticoagulate the patients properly, probably in some patients this doesn't make a lot of difference. Well, I'm not sure this applies to patients with structural heart disease, and I'm not sure this applies to HCM specifically. I hope we can discuss this tomorrow maybe as well. This is because there are pros and cons, as you know, for both, with regard to both strategies, but obviously stroke volume, cardiac performance will be reduced in these patients following the onset of AF, and these are often very young patients. And the other thing that is important to remember is that we don't know whether the conclusions of the AFFIRM trial, for example, apply to these specific subgroups. For example, this is a meta-analysis, and this is not HCM, these are just a huge meta-analysis on atrial fibrillation patients. But what you see here is that the higher the embolic risk, the higher the benefits of rhythm control. So the lower the event rate, of course, in rhythm control. So it appears to be more beneficial to aim for maintenance of sinus rhythm in higher embolic risk patients, and HCM patients are definitely high risk patients. And I will just very briefly go through management issues because, again, there are people here in the audience and much more expert than I am in terms of treating atrial fibrillation specifically. However, as far as HCM is concerned specifically, we have limited resources in terms of pharmacological treatment. Disopyramide is the only class 1 agent we are confident in using because there are registries. It is usually used to control the gradient because it is a negative inotrope, but it does to some extent act on atrial fibrillation as well. Otherwise, we had to go for sotalol, dronedarone, which are usually not very effective once the disease is advanced. Amiodarone is by far the most potent, and as you know, also one of the most toxic agents that we have. We need to have better. There are interesting data coming from late sodium carbonate inhibitors, including ranolazine, which may have some effect on atrial fibrillation, but definitely would not be as potent as amiodarone. Another concept that is important with regard to antiarrhythmic therapy is that if you have young patients with large left atrium, we should consider AV node blockers. For example, this is a good reason to give beta blockers even in asymptomatic patients if you fear that may go into AF with rapid rates and then deteriorate. I will not go into catheter ablation except to show a couple of studies in which we have taken part, because again, there are people here much more expert than I am. But of course, because these patients are young, because of the early onset, and because they often don't tolerate the drugs for very long stretches of time, catheter ablation is a very interesting approach in HCM as in any structural heart disease, although it has been mostly investigated in non-atrial fibrillation. So the studies on structural heart disease with catheter ablation techniques are still limited, and HCM is no exception. This is currently the largest series published to date, and in which we have participated as a collaboration with the groups in Turin and Bordeaux and Michel Assaguer. And it is 61 HCM patients who were selected because their atrial fibrillation was recurrent, resistant to at least 2 antiarrhythmic drugs, including amiodarone, sequentially provided, and very symptomatic. So these were the worst patients, the ones in which we felt a little desperate. These were very difficult patients to ablate. The average left atrial volume in these patients was 150 cc's, so incredible remodeling, very difficult substrate, and myopathic substrate. So there was really doubts whether the procedure would work and how they would work. And in fact, as you would expect, pretty much the results are pretty much consistent with other studies on structural heart diseases. The studies were safe, the procedure was safe. However, there were recurrences in particularly the success rate was particularly low in patients with permanent AF, quite encouraging in patients with paroxysmal atrial fibrillation. 71% is actually good, but there was a 52% with due procedures. This is something we have to tell the patients. They will not be signing for a procedure, they will be signing for a strategy, so they would be prepared, they have to be prepared to go in for at least 2 procedures in 50% likelihood. And several patients will not be able to withdraw their antiarrhythmics because they have ventricular arrhythmias or because they may recur despite the ablations. Having said that, we were ultimately happy with the way things turned out. If you compare the results of at 2.5 years compared to, for example, this recently published catheter ablation meta-analysis published on any all comers in other associations and other institutions, you see that we compare favorably with the procedure in the general AF population. So we have to be reasonably happy with the results, considering that this was a very extreme selected subgroup. And as not surprisingly, the predictors of outcome of the procedure were the younger age, smaller volume, less duration of the arrhythmia, less symptoms. So the message is, if we want to pursue ablation in these patients, let's try to do it as early as possible and not leave it for the very late. And a lot of these patients were really very advanced. Just to finish off by saying that we also have families in which on top of HCM, we do have recurrent atrial fibrillation as a primary component of disease. Patients who have HCM and start fibrillating very, very early, and there's not enough hemodynamic substrate to justify a secondary origin of there really seems to be co-segregation of the 2 phenotypes. This is, for example, one family in which it's a huge family, as I will show you. The phenotype is atypical HCM with mostly apical hypertrophy, non-compaction, and in some cases, not in all, restrictive evolution, benign. The proband is now 90-year-old and is still active, so not a malignant form at all. And everybody in the family has at very young age, thousands of supraventricular ectopics followed by atrial fibrillation. This is the pedigree, as you see, the different manifestations of the disease. And we did find an actinin 2 gene mutation, which is novel and is consistent with other pedigrees with showing the same gene as a culprit. However, with next generation sequencing, we are beginning to see this. We have also found a novel mutation in a potassium channel gene. We are seeing this increasingly. It's very hard for us to know whether these are actual what modifies a disease causing the arrhythmia per se or whatnot, and we are now try to co-segregate this mutation with the family and with the other phenotypes. Next generation sequencing is definitely opening up a lot of issues here, raising more questions than answers, but this is definitely a very exciting step forward. So I would like to conclude just by saying that in inherited heart muscle disease, particularly hypertrophic cardiomyopathy, we have to consider we are dealing with a very likely myopathic atrium, tends to dilate very, very frequently. However, atrial fibrillation most commonly is a mix of the myopathic involvement and hemodynamic pathophysiological aspects of the disease, specific and most importantly, those related to heart failure and disease progression. Once atrial fibrillation occurs, it is an important marker of outcome, stroke risk, and quality of life. And what it does, it changes management forever after the first onset. I'm not so convinced we should aim for rate control in these patients when they're young. We should probably pursue rhythm control aggressively when indicated, but if we want to do so, we have to do this early. Thank you very much.